Thank you very much. My name is Jeff Weber. I am a medical oncologist at the Moffitt Cancer Center in Tampa, Florida, and we're going to be talking not just about the principles and application of immunotherapy for cancer, but we're going to be talking about how it applies to advanced melanoma. And again, these are the faculty members. It's me and Peg Esper, who's at the University of Michigan. And again, just to emphasize, there will be an attempt to measure the educational impact of the session, and so there are two colored handouts. The yellow handout should be completed prior to beginning, and the blue handout should be completed at the end of the presentation. Okay, so here's the agenda. We're going to talk about melanoma in the immune system, which has had an awful lot of attention lately. We'll talk about defining the role of the immune system in cancer in general, what it means to have tumor escape from immune surveillance, and how we might harness the immune system for melanoma treatment. And again, we'll talk and we'll go through the efficacy and safety issues about currently approved agents, and we'll spend a little bit of time on a topic that's of importance to any practicing oncologist or other professional who's going to be dealing with patients getting immunotherapy, that is, managing the adverse events that are associated with immunotherapy. And finally, we'll spend a little time about some novel agents and immunotherapy combinations, which have gotten a lot of attention lately. So first, you have to understand a little bit of basic immunology, and this takes you back to medical school. In some cases, it even takes you back to university, because there's the so-called first signal where if you look at the upper right-hand or upper left-hand corner, and I can use my mouse, I'm not sure if you all see it, but if you look at the immune T cell, the CD8 T cell, that's the killer cell, which recognizes the tumor cell by recognizing that little red thing, which is a little peptide, a fragment of a protein that was processed inside the cell and spat out at the surface in the context of what's called class 1 MHC. Now, that antigen can be secondarily presented by what's called an antigen-presenting cell, that big blue thing on the right, and that can either present antigens in the context of a different type of MHC, class 2, or it can secondarily or reprocess the class 1 antigen in the context of class 1, which you don't see, which also exists on the antigen-presenting cell, and it shows it to the T cell. Up here, the CD8 T cells are the killers. Here, the CD4 T cells are the so-called helper cells, and they work together to try to mediate an immune response against viruses, against even bacteria, and of course, although we wish it were better, against cancer. And the immune system is a very powerful force for good, but obviously if it's unrestricted, you develop autoimmunity. As you can imagine, over evolution, there's been many different molecules that have evolved to act as brakes or accelerators, and there are probably more brakes than accelerators because the organism has maybe more of an interest in suppressing immunity so you don't develop autoimmunity. But if you look on the left side, the little green molecules are all activating molecules. The ones on the right, the red ones, are all inhibiting molecules. So in cancer, as you can imagine, you don't have an adequate immune response, so you want to either overcome the inhibitory influences or promote the stimulating influences. And on the left, promoting the stimulating influence can be hard because you risk autoimmunity. But the greatest success so far, as you'll hear in a few minutes, has been in overcoming these inhibitory signals, which are called checkpoints. So checkpoint inhibition is where the success has been, and the new drugs have been approved. So if you look at and see what happens in the context of the tumor, in step 1 you have these so-called antigen-presenting dendritic cells. They cruise along and they can pick up a tumor antigen. That could be something shed by the tumor. It could be a piece of a tumor that's partly destroyed by chemotherapy, for example. And it presents it to the resting T cells, which hang out in the lymph nodes. And think of the lymph nodes as it's like a barracks for the soldiers of the immune system. They're just hanging out, ready for action. And they cruise by, they see the tumor antigen presented on this antigen-presenting cell, and they get a signal to get activated, and they eventually make their way to the periphery, not just hanging out in the lymph node, but they get to the tumor, and in the tumor microenvironment, if they're lucky, they avoid the immunoinhibitory influences in the tumor microenvironment, and they secrete things called perforin and granzyme. They secrete cytokines, all of which have the ability to cause regression of tumor if things go as we hope. The problem is there are many dampening influences on the immune system in cancer. There are so-called inhibitory receptors. So what you might see on the tumor cell is PD-1, which binds, or sorry, PD-L1 on the tumor, which binds to PD-1 on the immune cell. And when that happens, it puts the brakes on the immune response. Or the T cell might secrete something or generate something called CTLA-4, which blocks the stimulatory influences on the dendritic cell from activating other immune cells, and it turns off the immune response. And there are also suppressive enzymes like IDO, arginase, which put the brakes on. You have these T regulatory cells, which dampen immunity. You have myeloid-derived suppressor cells. So when you think about it, it's amazing that the immune system works at all in cancer, given that the tumor has the perverse, diabolical ability to subvert normal immune suppressive mechanisms that we all need to stay healthy. They use them, they subvert them to turn off the immune response in the tumor microenvironment. So when you think about it, it's amazing that it actually works. And turning off the suppressive influence like PD-L1, PD-1 interaction in the tumor microenvironment is a very key thing to do, and that's what the so-called PD-1 antibodies do. So let's move on, and let's talk about immunotherapy for melanoma. Immunotherapy has been around for a long time. If you look at what I'm about to show you here, this figure out of an article by Mike Atkins and JCO, this is something like 16 years old. This is 1999. And it's based on work that was actually done in 1985 when I arrived at the surgery branch of the NCI in Bethesda. And what it shows is that patients with interleukin-2, if they get a response, can stay there for a long time. And if you're the 5 or 6% of patients that get high-dose interleukin-2, an immune stimulant, and you get a complete response, you're going to stay there for a long time. And here is in the blue line, it's the complete responders. And look how far out they are. This is 10 years of follow-up. So what it says is if you get a response to high-dose interleukin-2, you're probably going to do well for a very long period of time. But it's the complete responders, which are a small minority, 6%, that are the ones that benefit. So if you're the lucky few using this FDA-approved drug, which was approved in 1998 for melanoma, you're probably going to be cured of melanoma. But again, 6% of them are complete responders. 2/3 of those 6%, which is 4%, stay in remission. That's a very small number of people who might be cured of their melanoma. And that's the good news. The bad news is it's very toxic. It's a complex regimen. It needs to be delivered as an inpatient, and only patients under the age of 70 who are in good shape, who can pass a cardiac stress test, would be good candidates for high-dose interleukin-2. It is used only in selected experienced centers. And frankly, all the efforts over the last 20 years to make IL-2 less toxic and more tolerable have completely failed. And I've been involved in a couple of those trials. But what does it say? It says it's proof of principle that immunotherapy can produce durable benefit in patients with cancer. It works in renal cancer where it's approved. It works in melanoma. But boy, we certainly needed, and this is 1999, we certainly needed then new immunotherapies. So, discussion. Let's talk about a case study. 78-year-old white male presents to a local emergency department with symptoms of weakness and dizziness and has melena, with a history of a thick truncal melanoma resected with a wide local excision and a negative sentinel lymph node biopsy 9 years ago. CAT scan shows multiple mediastinal masses, and at the time he gets an urgent laparotomy because of the obvious GI bleed, he has multiple small bowel masses. The obvious ones causing the bleeding were resected, and of course they were positive for melanoma, common presentation of metastatic disease. After he recovers, his performance status is 1, and he has a history of atherosclerotic coronary artery disease post 2-vessel stenting 6 years ago, so he has significant heart disease. And he's not that old, or pardon me, not that young, he's 78. So how would you select the best therapy for that patient? That's the first question. So let's think about the background to the kind of choice of drugs that we would make for a guy like him. I told you that there are many brakes on the immune system. We call them checkpoints. So there are 2 ways to block the checkpoints. One is at the point where the immune system is getting primed in the lymph node, not in the tumor, but in the lymph node. And that's where the dendritic cell is presenting an antigen to these T cells that are hanging out in the lymph nodes. And the T cell needs an interaction of something called CD28 with B7 on the antigen-presenting cell, because the interaction of the T cell receptor on the T cell with its antigen is not enough to stimulate the T cell. You need other interactions because the T cell receptor interaction with antigen is a pretty weak one. So what happens is the immune cell upregulates CTLA-4, which prevents the secondary interaction between B7 and CD28, and it shuts off immunity. If you could eliminate the shutoff, meaning you could eliminate or inhibit the inhibitor with an antibody, either ipilimumab or, and there was another one, tremelimumab, you might allow the immune response in the lymph nodes in the periphery to proceed in an unfettered manner. That's a good thing. Once you get in the tumor, it's a different way of suppressing immunity. The tumor, as I said, diabolically upregulates PD-L1. That's the PD-1 is a receptor on the immune cell that's one of the brakes, the checkpoint. PD-L1 is its ligand. PD-L1 meets PD-1, boom, T cell doesn't work anymore. If you block that interaction with an antibody, and my God, as you can see here, there's 6 of them, you would interrupt the inhibitory checkpoint and allow the T cell to work in the tumor microenvironment. And that's the genesis of these antibody treatments that disrupt immune inhibitory checkpoints. And the first one we're going to talk about is ipilimumab, which disrupts the interaction between CTLA-4 and B7. Back in 2010, were presented the first data published in New England Journal with Steve Hody as the first author, showing that if you took second-line or third-line melanoma patients who in those days had no treatment, no standard, no established treatment, nothing, you treated them with ipilimumab with a vaccine called GP100, or just ipilimumab, or the vaccine alone, which, by the way, we figured was just essentially going to be a placebo. You saw in a fairly well-done randomized trial with a 3-to-1-to-1 randomization, so imbalanced randomization, but 676 total patients, a very good-sized study. The green and the yellow are clearly better than the brown, so it's obvious ipilimumab, the antibody that blocks CTLA-4, with or without a vaccine, didn't matter if you had it or not, was clearly superior to the vaccine, which, in my view, is kind of like a placebo. And if you look at the survival, 10 months versus 6, hazard ratio, a 32% reduction in the risk of death, p-values were excellent. So no question, this was a drug that had some survival benefit. And normally in melanoma, second or third line, 10% at 3 years is what you'd see. Now we're bumping the plateau up to 20%. So it looks like it was an improvement, and indeed in 2011, ipilimumab was approved for the treatment of second-line and first-line metastatic melanoma. So this was the first immunotherapy ever tested in a randomized trial. And if you look at the landmark 1 year, 2 year, and then you go beyond 3 year, 4 year survivals, ipilimumab with or without the vaccine clearly superior to the control arm. And it became evident early on that we were seeing some strange responses. This is an exaggerated view of a response where a patient will progress before they actually regress. So this is what you call an unconventional response of a patient with multiple skin lesions that are really ugly and ulcerated on the back. At screening, 8 weeks into treatment, they've had 3 doses of ipilimumab. Man, it's getting worse. It's pretty obvious it's all ulcerating. But if you wait and are patient, week 12, looks like some of them are shrinking. Week 16, more of them are shrinking. By a year, they're all disappearing, and here's week 72, a year and a half later, almost all gone, continued complete remission 2 years later. It's all healing up. And this is a patient that had a long-term response, but if everyone had bailed out at week 8, he would have been called a progressor. In fact, this was a responder with a complete remission in a patient who clearly benefited, pointing out that between 5 and 10% of the time with ipilimumab, with PD-1 antibodies that you'll hear about in a minute, there's no question you have to be very careful. You have to know when to hold and when to fold, as Kenny Rogers would say in his song, The Gambler. You have to know when to hold on and keep treating in a patient who might have a late response, what we call an unconventional response. Over time, in looking at patients who got the drug ipilimumab, if you were in remission, stable or PR or CR, at 3 years, where the red dot is, they plateau out. There's a lot of follow-up here in patients almost out to 10 years. And with long-term follow-up, it's pretty clear that when you have a response or are stable to ipilimumab, and it stays there at 3 years, you're probably going to keep it for a long time. And For the first time in metastatic melanoma treatment, we began to talk of cures. So very impressive results published now in the journal Clinical Oncology just this year by Dirk Schottendorf. So, second case study. 58-year-old male has a history of melanoma. He has stage 3B disease on the back of the neck and positive axillary nodes, all completely resected, and he develops another incidental stage 1 melanoma on the shoulder, completely resected, very thin, so no sentinel node biopsy. Several years later, 2 pulmonary nodules arise in the right lower lobe, biopsy positive for melanoma. They were very close, so the surgeon felt they could be completely resected, rendered the patient free of disease. However, in 2013, a couple of years later, the patient presented with 3 growing liver lesions, and this time they couldn't be resected. And testing showed that the patient was BRAF wild type, which is pretty common when you get over the age of 50. Usually you do not have that mutation. The liver lesions were treated with radiofrequency ablation, but 6 months later on follow-up, guess what? Multiple new lesions. The patient initiated treatment off protocol with ipilimumab, but during his third treatment, his third cycle given every 3 weeks, he had frequent watery diarrhea up to 9 times in 24 hours. That frequent watery diarrhea then progressed to bloody diarrhea very quickly upon him calling into the office and being seen urgently. How would you manage this patient? That's the question. This is a patient with colitis. Anyone who has more than 7 diarrheal bowel movements in a day above and beyond the baseline, or who has bloody diarrhea, by definition has colitis, which is a not uncommon complication of ipilimumab occurring at grade 3 or 4 and up to 7% of patients. And if you look at the left, that is an ugly, ugly appearance on colonoscopy of the descending colon. That is bad news. That's a thickened bowel wall, that's ulcerations, and if you look microscopically on biopsy, inflammation in the crypts, all those little blue dots, they do not belong there. They are lymphocytes, and focal active cryptitis. Bad news, a patient with big-time colitis. That patient needs to go on serious steroids, because if you look at the immune-related adverse events, as we call them, which are the side effects of ipilimumab, if you look at the grade 3-4 side effects, in parenthesis, if you look at ipi with placebo, 12% of the patients are going to have some grade 3-4 side, grade 3, 2% grade 4 added together. It's about a 14% rate, about 1 in 7 rate, as I tell the patients, of developing significant side effects from ipilimumab. And they come down to skin, GI, endocrine, and more rarely hepatic. And we just saw the GI side effects. About 7% of the patients are going to have grade 3-4 colitis with ipilimumab. That's a serious side effect. And these immune-related adverse events have a characteristic kinetics. First, the skin, which takes a little bit to resolve. Then comes the colitis and diarrhea, just like in this patient after 2 or 3 doses. After 3 or 4 doses, you get the liver toxicity, which takes quite a while to resolve. And at the same time, toward the end of those 4 doses, you can get endocrinopathies or hypophysitis. And the reason why that curve doesn't come down to the baseline is many of those patients may have their pituitary knocked out for the rest of their lives and be put on replacement steroids. However, virtually all of the immune-related adverse events with this drug can be managed successfully with steroids or other treatments. The keys to managing these side effects, at the baseline, you need a good history. You got to define the thyroid function and the LFTs at baseline. And with subsequent doses, we check thyroid function, we check liver functions, because we want to worry about developing hepatitis or hypophysitis, which is inflammation of the pituitary. And if somebody presents with these symptoms that may be immune-mediated, you have to do a thorough evaluation. And you have to educate the patients about the key points about these immune-related adverse events, the importance of promptly calling in. You have to make sure the patients understand what these are, and you have to emphasize that some of these symptoms may come and go, and even after getting treated, there may be a recrudescence of symptoms. So the patients need to communicate with the doc very well when thinking about these treatments and these side effects. And again, we don't need to go through the details of all of them, but the GI tract is the one thing that gets your attention because colitis can lead to obstruction, perforation, toxic megacolon. If you get grade 3 or 4 colitis and or diarrhea, you're done with ipilimumab. And if you're refractory to steroids, we use infliximab, which is a TNF blocking antibody. Very important, can be almost a miraculous treatment. A lot of patients have rash. It's the most common side effect, mostly grade 1 and 2, rare to see it grade 3. Usually it's a diffuse maculopapular rash, and it's not usually dose limiting. Liver toxicity, often we'll see asymptomatic modest level rises in AST, ALT. Often you can hold a dose, continue, not a problem, but if the AST, ALT goes up above a certain point, you got to stop. CNS toxicity is rare. Neuropathies are what happens. If you have a serious neuropathy at grade 3, you got to stop. Endocrinopathy, almost all grade 2, you can give replacement steroids and keep going with ipilimumab. And with the eyes, if you develop uveitis, that's not uncommon. It's almost always reversible quickly with steroid eye drops. If it does not, you got to stop the drug. So if you get reversibility within 72 hours of your symptoms of uveitis and vision problems, and you treat with topical steroids, you can continue IPI. If not, you got to stop the drug. So again, you got to hold the drug if it's grade 3, 4, or continued grade 2. We give serious doses of prednisone, 1 to 2 mg per kilogram. And if you don't get resolution of your GI symptoms, especially within 72 hours, you give a dose of infliximab. If it's hepatitis, you then give mycophenolic acid. You don't give infliximab for hepatitis, but it can actually cause hepatic toxicity. The big issues with IPI that remain is 3 mg per kilogram, the approved dose, or 10 milligrams per kilogram, which has also been used. Which one's better? And there was actually a phase 3 trial comparing the two. It's pending. As you can imagine, both doses give benefit, so you're going to have a long wait to see a significant difference between the two arms of that study. We don't know whether it's best to give 4 doses of IPI and stop, or give 4 doses of IPI and maintain them every 12 weeks for a year. That's been compared. And there have been promising initial adjuvant data on IPI versus placebo that show benefit in terms of relapse-free survival. We don't have survival data. And there's been an ECOG trial called E1609 that compared IPI at 3, IPI at 10 with interferon. Those results we won't know for a couple of years. Finally, lots of combinations with IPI. Bevacizumab and or GM-CSF with IPI looks very promising and needs to be followed up. And local therapies like T-VEC, the injectable herpes virus, looks very interesting with IPI. And finally, we'll hear briefly that IPI with nivolumab, one of the PD-1 antibodies, just got approved by the FDA at the end of September, the last day of September, as a matter of fact, September 30th. And those results look fantastic with up to a 60% response rate. But watch out, don't combine BRAF inhibitors close in time with IPI. It causes a lot of hepatic and skin toxicity. Just a brief snapshot. If you look at IPI combined with GM-CSF, which was conducted in a small phase 2 study by Steve Hody, compared to IPI alone, it looks like the combo is better. And again, the p-value is borderline because there weren't that many patients on the trial. It wasn't a big randomized phase 3 trial. Looks interesting and looks like it deserves to be followed up. And interestingly, you had fewer toxicities in the combo arm than in the IPI alone arm. So, case study. 76-year-old male presented with a lesion on his left neck in 2012, which was diagnosed as stage 1 melanoma. In January 2013, a lesion appeared on the vertex of the scalp. A wide local excision was performed without sentinel lymph node mapping. In April 2014, a 1-centimeter nodule was detected in the graft. A brain MRI was negative for metastases, but this time a CT of the chest, abdomen, and pelvis showed 2-centimeter pulmonary metastasis, a destructive bone lesion in the right eighth rib, and both of these lesions were biopsied and both were positive for BRAF wild-type melanoma. So no BRAF mutation. He received 4 cycles of ipilimumab, and then he had some size increase and increase in the number of the scalp nodules, fatigue, weight loss, increased rib pain, and new liver lesions. And the question is, do you want to hold or do you want to fold? And that's the issue. I told you that in some patients, 5, 6, 7, 8% of them, you may have progression followed by regression, but not always should you keep treating when you see progression with ipilimumab. Now, we talked about blocking immune checkpoints. The immune checkpoint that's received the most attention recently is PD-1 on T cells, which is a receptor. It binds to its ligand PD-L1, paradoxically or almost perversely, ectopically expressed on tumor cells. So think about this. Normally, immune cells suppress one another by having the PD-L1 on, say, the macrophage bind to PD-1 on the T cell, and it shuts off the T cell from becoming too activated and causing autoimmunity. The tumor hijacks the PD-L1 by being able to express it ectopically and has its own ability to shut off immunity, so it's really diabolical. And if you could prevent that shutoff, you could allow the tumors, or the T cells in the tumor microenvironment to do their thing without inhibition, and that would be spectacular. And now there's 6 antibodies in development, 2 of which have been already approved by the FDA, that block the PD-1, PD-L1 interaction. And again, some of the first data were from a phase 1 study of a drug called pembrolizumab, a PD-1 humanized antibody, published 2 years ago by Omid Hamid in the New England Journal. And look at that fantastic waterfall plot, almost as good as a BRAF drug. And if you had prior IPI or no prior IPI, you could still have great responses. The response rate in the group as a whole, and this was a big number of patients, 135 patients, 37% response, 81% ongoing with not quite a year of follow-up. And again, fantastic result that ultimately led, with other data to support it, to the approval of pembrolizumab by the FDA in September of 2014. Very impressive early phase 1 data. That phase 1 trial, by the way, went on to accrue over 400 melanoma patients, the biggest phase 1/2 trial in the history of oncology. Nivolumab is the other antibody. They come from different companies. Nivolumab is an IgG4 human antibody as opposed to humanized antibody for pembrolizumab. And again, it has a good response rate in patients who failed other therapy of 31%. Many of the patients on that spider plot have good responses that are deep. And if you look at the responses, something like 58% of them were ongoing at the time of the response. All these were heavily pretreated patients. Many of the patients on the prior slide had no other treatment. They were frontline patients, different category. But still, even in the bad actors who failed all other therapy, can't complain about a 31% response rate. And these data, plus others, led to the approval of nivolumab by the FDA 3 months later in December of 2014. If you look at the pembrolizumab adverse events, you can tell immediately whether it's at 2 milligrams per kilo or 10, relatively small numbers of patients had significant grade 3-4 adverse events, much different than ipilimumab, probably half or even a third the rate of grade 3-4 toxicity. Very impressive. And if you look at Nivo, the same thing. In the initial nivolumab phase 1 trial of 107 patients with melanoma, any grade 3-4 AE was 22.4%, but if you look at the ones due to drug, it was about 8%. Clearly beats the 14% rate of grade 3-4 adverse events with IPI at 3 per kilo, and beats the heck out of the 25% rate of those toxicities, excuse me, with ipilimumab at 10 milligrams per kilogram. And again, a number of randomized trials were then done with these drugs because the FDA, of course, can approve a drug on the basis of a phase 2 study, but it demands randomized data subsequently. So IPI at 2, pembrolizumab at 2, pembro at 10 was compared in second line to investigator choice of chemotherapy. And again, the progression-free survival and survival were the endpoints here. So this was a second or third line trial of pembrolizumab in the IPI refractory population. And again, the results in terms of PFS are very clear, already been published by Tony Rebus. If you look at the progression-free survival curves, whether you give pembro at 2 or 10, clearly superior with an early break at 3 months from chemo. No question, the p-value is spectacular. The hazard ratio shows almost a 50% decrease in the likelihood of progressing if you give pembro at either dose compared to chemo. So in IPI refractory patients, second line, a lot of support for the registration of pembrolizumab. And if you look at similar study with nivolumab, it was a slightly different design. It was a 2-to-1 randomization of nivolumab at 3 per kilo versus investigator choice chemotherapy in IPI refractory patients. And here the endpoint was response, and it's pretty obvious. Look who the winner is, 32% for nivolumab, only 11% for the investigator choice chemo. We don't have mature PFS or OS, but it looks pretty good. And if you look at these two studies, good number of patients in randomized phase 2 or phase 3 studies, similar doses, although Nivo is every 2 weeks, Pembro is every 3 weeks. Response rate looks a little better with Nivo, 32 versus 21 for Pembro. But if you look at the grade 3-4 drug-related toxicities, well under 10%, these drugs are safe and their toxicity profile clearly superior to what you saw with ipilimumab alone. If you look at frontline studies, again, this was done in Europe. It was nivolumab at 3 per kilo versus dacarbazine, because we couldn't use dacarbazine in the U.S. in those days. We already had IPI approved in frontline. In the EU, they didn't have any frontline therapy, so this was a straight-up frontline Nivo versus chemotherapy trial. And take a look at the survival curve. It's pretty obvious from across the room which one is better. Nivo in blue, chemo in yellow. The survivals at 1 year were spectacular for nivolumab, 73%. 40% response rate, outstanding. 13% for chemotherapy, better than we usually see, actually. And this was published this year in the New England Journal. Very impressive frontline result, which supported the first and second line registration of nivolumab. And again, similar kind of trial for pembrolizumab. It was this time done in the U.S., so you had to have IPI as your control arm. Pembrolizumab at 10 per kilo every 2 weeks, 10 per kilo every 3 weeks, or IPI every 3 weeks for the 4 standard doses. And the endpoints here were progression-free and overall survival. If you look at the PFS, doesn't matter which dose of Pembro you use, clear superiority to IPI, spreads apart at 3 months, stays apart. If you look at the survival curves, not as impressive data because they're short follow-up, but again, looks like there's an obvious superiority of Pembro at either dose versus ipilimumab in terms of both progression-free and overall survival, just published by Caroline Robert in the New England Journal. Impressive data suggesting that both for Nivo and Pembro, first line or second line, clear superiority to any reference control arm. Now let's talk briefly about the combination of nivolumab and ipilimumab, because if either one works, and they work by different mechanisms, and there's animal data to support the combo being better than either drug alone, let's see what happens in humans. Well, this was the so-called BMS 067 study, and this was a randomized phase 3 double-blind study of Nivo at 1 and IPI at 3 for 4 doses, followed by Nivo at 3 until progression or unacceptable side effects, or Nivo alone at 3, the standard dose, or IPI alone at 3, the standard dose. And if you got Nivo, you kept getting Nivo in maintenance until unacceptable toxicity or progression. If you got IPI, IPI is only approved for 4 doses by the FDA, so you just got placebo. And here, the endpoints are response and progression-free and overall survival. Now, frankly, we don't have any survival data because it's immature, but look at the PFS data. I'd rather be on that blue line than on that orange line or that green line, and it's obvious the combo overall has a better progression-free survival that splits apart early at 3 months, time of the first evaluation, of course, compared to Nivo alone or Pembro alone. Nivo looks better than Pembro, but that wasn't the point of this study. We already know Nivo is better than Pembro, or pardon me, Nivo is better than IPI, excuse me. It's that the combination looks superior to either drug alone. And the 1-year survivals of prior studies, phase 2 studies, showed that you had an 88% 1-year survival. That is phenomenal, never seen with melanoma. So this and the so-called 069 study of IPI plus Nivo versus IPI alone, showing superiority, led to the approval of the combination in those who were BRAF wild type based on those data and data from the 069 trial. And that happened at the end of September. Interestingly, if you're PD-L1 positive, which is a potential marker for the efficacy of this type of drug, if you look at the left-hand column, if you express PD-L1 on the tumor, which I told you diabolically tends to upregulate this, look what happens. There's no difference between the combo and Nivo alone. But if you look at PD-L1 negative, meaning less than 5%, those are the patients where the combo is clearly better than either Ipi alone or Nivo alone. Now, I'm not advocating going ahead and testing for PD-L1 and not using the combo if you're positive, but it sets up a potential prospective study in which you would stratify by PD-L1 staining prospectively, and if you're PD-L1 positive, consider just giving Ipi alone, or pardon me, Nivo alone, or the combo. And if they're the same, I'd go with Nivo alone, but the answer is not quite clear on that point. Very thought-provoking. On the downside, look at the side effects of the combination. Look at the two left-hand columns and go one in from the left. It's the grade 3-4 toxicities that are immune-related with the combo. It's a 40% toxicity rate. Adding in all the grade 3-4 toxicities, immune or not, you get about a 50% rate of grade 3-4 toxicity with the combo, which is no comparison to what you see with either drug alone. So it is a much more toxic regimen, and a good 18 or 20% of the patients can't get past the first 12 weeks, just have to go off treatment. So this is a pretty toxic regimen. Look at the rate of hepatitis, 19%, GI, 15%, endocrine, 5%, much higher than nivolumab or ipilimumab alone. So are those toxicities reversible? Virtually all of them. They all get steroids, but still, it says the combination may not be for everyone because of its side effects. So let's do another case study. 69-year-old patient with recurrent melanoma is currently receiving pembrolizumab. Between cycles 2 and 3, the patient complains of mild diarrhea and a low-grade fever. On exam, his labs show an amylase of 450 and a lipase of 400. Now, in our place, that's something like 4 times normal. The patient has had continued fatigue, but his weight's stable and no abdominal pain. How would you manage the patient? Would you hold the therapy? Would you discontinue it? In other words, what would you do for grade 2, 3 amylase and lipase elevation in the face of no specific symptoms of pancreatitis or evidence of pancreatitis, other than the biochemical evidence? That's the question. Now, we talked briefly about PD-1, PD-L1 axis, and we talked about 2 PD-1 drugs now approved for metastatic melanoma, pembrolizumab and nivolumab. Like ipilimumab, they can cause these treatment-related so-called IRAEs, immune-related adverse events. Spectrum is similar, but it's not exactly the same because with these drugs, you now begin to see pneumonitis, inflammation of the lungs. And if you see grade 1 isolated hypophysitis or hypothyroidism, you can replace the patient and keep treating. You don't have to stop treatment. If you get grade 2 recurring side effects, you can hold the drug, give steroids, let it resolve, and continue treating. But if you get grade 3 events that don't go away quickly with steroids, you got to stop. No question about it. On the other hand, if you see grade 3-4 pneumonitis, nephritis, infusion-related reaction, you got to back off and give them steroids. Stop the treatment and give them a fair course of steroids. If you have hepatitis that's associated with the parameters shown here, that lasts more than a certain amount of time, you got to throw in the towel and give up. If you have low-grade abnormalities of LFTs, you can continue, but high-grade, not a good idea. And these kind of guidelines apply to both nivolumab and pembrolizumab. So, in that case study, we held the treatment. We initiated a Medrol dose pack, and the patient had a return visit in 1 week scheduled with labs. At the return visit in 1 week, the labs returned to grade 1, and even though there were grade 3 amylase and lipase elevations, cycle 3 was initiated. There was no further elevation of lipase and amylase beyond grade 1 to date, implying this was transient hyperamylasemia and hyperlipasemia. It wasn't really pancreatitis per se, because there were no signs and symptoms of pancreatitis itself, and we got away with continuing. Following cycle 4, radiographic and clinical evaluations showed disease regression, and this is a patient who continues on treatment to the present time without recrudescence of hyperamylasemia or hyperlipasemia. So again, patient education is absolutely critical when you're using these novel therapies. Patients have to know that the adverse reaction profiles differ from standard chemotherapy. They have to know that early recognition and reporting of these adverse events is critical for the safe treatment with these drugs. No question about it. They have to know who to call and when to call for adverse reactions. And the key to giving these drugs safely is to reinforce the teaching points to the patients. And it's obviously not always the docs, it's going to be the nurses, the nurse practitioners, the physician's assistants. The patients need to know what to call for and who to call, and the docs need to know when that should happen also. And having in your area an emergency room that can expect to see some of these patients, I think, is critical, because if a patient shows up in an ER referred by an oncologist, maybe somebody who's on call, the ER doc's going to have to know what to do and what to expect. So real quickly, future directions. I told you that this PD-L1 seemed to suggest that if you were PD-L1 positive, it didn't matter whether you gave PD-1 antibodies or the combination. Early on, there were thoughts that if you were PD-L1 positive, you had a greater chance of responding to these PD-1 antibodies. But in fact, that's probably true. But just because you're PD-L1 negative at the right side, you can still have a response, so you can't use it as a predictive marker. So don't use PD-L1 staining to decide to treat patients with PD-1 antibodies. Yes, the response will be higher if you're positive, but it ain't going to be negative if your PD-L1 is negative. You'll still have a good response rate. So it is not a good marker. Although, admittedly, take a look at the difference in survival in this study presented about a year ago. You can obviously have a better survival if you're L1 positive than negative, but you're still going to do better if you're PD-L1 negative receiving a PD-1 antibody than receiving, say, chemotherapy. Because look at this. This was in the original first-line study of nivolumab versus chemo. Whether you're PD-L1 positive or not, in the open triangle or the closed triangles, you do better than chemotherapy. So don't use PD-L1 staining other than as a research tool. So, PD-L1, not the world's best biomarker, and when I say biomarker, I mean predictive biomarker, meaning something you can use to decide to treat patients or not treat them. If it's negative, you should not decide not to treat. Why? Because it's an immunohistochemical assay. Different companies use different assays. Archived tissue that's 5 years old acts differently than recent biopsies. People argue what's a positive, what's a negative, and it's an inducible marker. So if you have a high T-cell infiltrate, you're more likely to be PD-L1 positive than PD-L1 negative. So if it's inducible by the presence of T-cells, man, that makes it a bad predictive marker. The best predictive marker is something that never changes, that's easy to assay, and PD-L1 is not that marker. So it's a great research tool, but don't use it to select your patients. The immuno-oncology field has almost unlimited potential. Look at all the different steps in the immune response that's shown in this article from Dan Chen and Ira Melman from a couple of years ago. There are seven different discrete steps in releasing cancer antigens, presenting them, priming them, trafficking the T cells to the tumor, getting them into the tumor, recognizing the tumor, and then killing them. Every step of the way, there are drugs in development that can promote the immune response to melanoma. And frankly, IPI and Nivo and Pembro are just at one of those steps. There are many other steps that we can intervene at. So that's all good news. So what's the conclusion? Immunotherapy for melanoma induces responses of long duration and can result in prolonged survival, like I showed you with nivolumab, pembrolizumab, ipilimumab. Novel patterns of response with these checkpoint protein inhibitors, that is, that one slide I showed you of these horrible ulcerated tumors growing bigger and then growing smaller, it happens between 5 and 10% of the time. So we need to develop new response criteria to accommodate this progression followed by regression or so-called unconventional responses. The immune-related adverse events are a unique spectrum of adverse events with checkpoint protein inhibition, and there's a learning curve, but again, we have very well-educated oncologists, mid-levels, NPs, PAs, and nurses in our country, thank God, and while there's a learning curve, everybody can handle it. It's just a matter of familiarizing yourself. Personally, I'd rather treat immune-related adverse events than prolonged horrendous thrombocytopenia and neutropenia from chemotherapy any day. And the good news is, in the immunotherapy field, best is yet to come. So, please complete your blue post-activity survey form and return it to the program staff. And I thank you very much for your attention. And I am available for questions. We have lots of time for chat, so if you have questions, feel free to fire away.